Hello everyone. I hope you're doing well. This is Dr. Hany, an Egyptian doctor. I finished step 1 and passed step 2 the score to 69. I've been tutoring medical content for over 5 years and step 1, step 2, step 3 content for over 2 years. I've helped a lot of students to achieve their goals, and all of my step 1 students who I tutored passed, and the average step 2 scores of my student is 255. Today I'm going to discuss with you guys very high yield respiratory concept in step 1, which is hypoxemia and how to approach it. But before starting, I need to clarify 2 points. One is that respiratory physiology, I know how frustrating it could be, but you should know, guys, that you should be focusing on the things that comes in the exam. There's a lot of equations out there that if you waste your time trying to memorize, trying to understand, it's not going to help you in the exam. And you may do a lot of effort to try to understand them. And at the end, you're going to get the question wrong. This is not the purpose of doing the respiratory physiology. You should be knowing what is the most important thing and the thing that comes in the exam, and you should understand. I don't say that you should not understand, but don't go beyond like where did those equations come from and all of this physics that is not gonna make sense for you while you're solving the exam. So I'm gonna be focused on the things, especially in hypoxemia. And the thing that you should be focusing in the exam and the thing that you should understand clinically. So this is the first thing I want you guys to understand, like the general concepts. I'm gonna focus on the things that you need for it in the exam. So this is the first thing. The second thing is that I want most of you guys to interact. I want most of you guys to type in the chat whenever there's something you don't understand. I would be more than happy for you guys to ask the question. The first half of this session is going to be focused on explanation and explaining how to approach hypoxemia. And the second part is going to be focusing on questions and solving from the Synapse QBank. In the first section, I want you guys to wait till I finish like the whole explanation, or I'm gonna divide it into points. I want you to ask your questions after I finish each point individually, because maybe I will answer your question or the question that is going to be in your mind. I'm gonna answer it in the explanation before you even asking. Okay? So those are the two main things. I want all of you to interact, guys. Okay? So let's start. uh, how to approach hypoxemia. The first thing that you should be knowing, guys, is that there is difference between hypoxia and hypoxemia. What is the difference between hypoxia and hypoxemia? Both of them are low oxygen. Both of them are low oxygen. But there's like a very significant difference between them. Hypoxia doesn't mean always that the patient is going to be hypoxemic. Hypoxia is less oxygen going to tissue or going to cells. So the patient is going to have decreased oxygen in the cell. Okay. What about hypoxemia? Hypoxemia is also decreased oxygen, but rather than decreased oxygen in the cell, it's going to be increased oxygen in the blood vessel itself. So there is a condition that led to decreased O2 in the blood vessel. Someone is going to ask me, Hani, doesn't it mean that when the patient is having low oxygen in the blood vessel, it means that he's gonna have low oxygen in the tissue? Yes, this is like the most common or the logical consequence of decreased oxygen in the blood vessel. However, not every cause of hypoxia or not every cause of decreased oxygen in the tissue is gonna be from hypoxemia. For example, I want you guys to answer the question I'm going to ask. What if I told you that the patient is having normal oxygen concentration or normal oxygen level in the blood vessel? There is normal PaO2. However, the patient is in shock. There is decreased blood pressure. Will the cell receive oxygen or not? No. Why? Because there's no blood supplies going to the tissue. So although that the blood vessel has oxygen, the tissue did not receive oxygen because there is no blood supply in the first place. So hypoxia is the broader term. It is a broader term. And it is a consequence, which means that there is less oxygen in tissue. And this could be caused by hypoxemia. Sorry for that. This could be caused by hypoxemia, like less oxygen in blood vessel, and could be caused by ischemia, less blood supply. And there are other causes that are not the scope of our talk today, but something else is anemia. When the patient is having anemia, he's having normal blood supply, he's not having ischemia, he's having normal oxygen in the blood vessel, but he's not having enough hemoglobin carrying oxygen. So will the tissue have oxygen, or will the tissue have normal oxygen or decreased oxygen in case of the patient is having anemia? Yes, amazing. So in short, what do I want you guys to know from this slide or from this section? Hypoxia has a lot of causes. One of them is hypoxemia, which is decreased oxygen in the blood vessel. Any decreased oxygen in the blood vessel is gonna cause hypoxia. But not every cause of hypoxia is hypoxemia. Is that clear, guys? Okay, amazing. Okay, so okay, we're gonna recap on all of this, guys. Okay, so hypoxemia. How do I know that the patient is having low blood or low oxygen in the blood? How can I know this? I know this by seeing the level of oxygen in the blood, level of oxygen. Okay? And let me break down a concept, the concept of partial pressure, because this concept is a little bit confusing. And me at first didn't understand what is the partial pressure. I was so confused, like, what is the meaning of it? It's a pressure. Like, how is gonna pressure be a level? So I want you guys to know what is meant by partial pressure. Partial pressure is the unit we use to measure the level of gases, whether it's in alveoli, whether it's in the vein, whether in the artery, whether it's in the artery. So the pressure is the unit of measuring the level of gases in general, not only oxygen. Okay. Okay. Again, the partial pressure is the unit we use to measure the gases level, whether it's in the alveoli or in the blood vessels. Okay. So when I tell you that we are having the partial pressure of oxygen in artery, it means that we measure the level of oxygen in artery. Always remember it like this, so you're not getting confused. Because I know pressure is not a unit we usually use to measure level of something. But in gases, we use it to measure the level of gases in general. So if I told you partial pressure of CO2 in artery, it means that I'm going to see the level of CO2 in arteries. Okay, so this is the first thing. So the partial pressure of oxygen in artery is called Pa small O2. O2. So Pa small O2 equals partial pressure of oxygen and artery. And what is the other name we named or we gave for the partial pressure? The other name is level, oxygen level, oxygen level in artery. So what is the PaO2 or the oxygen level in artery? That when it is lower than it, we say that the patient is hypoxemic. Does any one of you guys know? Yes, lower than 60. Okay, we say that the patient is hypoxemic when the PaO2 is less than 60. Someone said 90. Yeah, this is another cutoff value, but for the sub one, we need the one they use is less than 60. Okay, when the patient is having PaO2 less than 60, we say that the patient is hypoxemic. Okay, okay. So is this concept clear before going to the next one? We're gonna talk about all of this, guys. Just for now, is the concept of partial pressure okay? The hypoxia, hypoxemia. Is there anything not clear here? Okay, amazing. Let's go to the next one. Now we need to see the level of oxygen in different areas. We have PA small O2, which is the partial pressure in what? In artery. And we have the level of oxygen in the alveoli. The level of oxygen in alveoli. And this is abbreviated by PA capital O2. So we have oxygen here and we have oxygen here. Okay. So why is it important to know both? Like, are both of them are the same level? No, because in order for oxygen to go from alveolus to the blood vessel, it needs to diffuse, right? There is a tissue between them that the oxygen needs to diffuse to go into the blood vessel. And in the process of diffusion, some of oxygen is lost. So usually the level of PaO2 is lower than PA small O2 is lower than the PA capital O2, or partial pressure of alveolus. Let's call it partial pressure of alveolus, partial pressure in artery, not to confuse you guys. So some of oxygen is lost in the process of diffusion, and this is totally normal. Okay. And the difference between the oxygen in alveolus and the oxygen in the artery is called AA gradient. And this gradient is normal because in the process of diffusion, some of oxygen lost. I'm gonna talk about the normal values, but for now, just know guys that it should not be more than 15. It should not be more than 15. The AA gradient, or the decrease in oxygen from the process of diffusion from the alveolus to the artery, should not be more than 15. If the decrease is more than 15, it means that there is a problem in the transfer of oxygen from the alveolus to the blood vessel. Is this clear, guys? Okay. So let's talk about the process, about how oxygen from the first place goes into the arteries. It goes through a lot of processes. And in some references, you're gonna see a lot of nonsense stuff that is not gonna be asked and is gonna make it overcomplicated for you. I want you guys to divide it into two phases. The phase that the air or the oxygen is going from the normal air or from the atmosphere air to the alveolus, and the second step is moving of the oxygen from the alveolus to the blood vessel. So the first process is the transfer of air from the atmosphere to the alveolus. This process is called ventilation. So what is ventilation? Air going in from atmosphere to alveolus. Okay, and this process is called ventilation. Okay, so when the air reaches the alveolus, here, let's say O2, when the oxygen reaches the alveolus, in order for it to go to the pulmonary vessels, it should go through the process of diffusion. It should diffuse from the alveolus, going through interstitial tissue, and then is being transferred to the pulmonary capillaries or pulmonary vessels. And as I said, in this process, some of oxygen is lost. This process is called diffusion. So the two processes that I want you guys to memorize by heart in order for the oxygen to go from the atmospheric air to the arteries is the first step, ventilation, air going in from atmosphere to alveoli, and the second step, diffusion, the transfer of oxygen from the alveoli to the pulmonary vessels. And why is this important? Because this is gonna make up the differential diagnoses when we talk about hypoxemia. Okay, so let me ask you something, guys. What will happen to the AA gradient when there is a problem in the diffusion? The oxygen is going to the alveolus, but it cannot, or it is it cannot, or it is slowed by like there's a pathology that led to decrease in the diffusion from the alveolus to the pulmonary vessels. What will happen to the AA gradient? Okay, so let me break this guy. So the PaO2, or the partial pressure in the alveolus, is gonna stay the same, right? However, when there is a problem in the diffusion, what will happen is that there is less oxygen going to the arteries. So there will be decreased in the partial pressure of arteries. And since the partial pressure in the alveolus is the same, and the partial pressure in the arteries is gonna be decreased, you're gonna expect that the AA gradient is gonna be increased. Yes, this happens in a diffusion process, in a diffusion problem, when there's a problem in the diffusion itself. So let me ask you something, guys. If there is a problem in the ventilation, there is something that led to decreased ventilation. What do I mean by decreased ventilation? Decreased air going in. What will happen to the partial pressure in the alveolus? What will happen to the partial pressure in the alveolus when there is decreased air going in? Yes, it will be decreased. And by default, since there is decreased oxygen going to the alveolus, there would be decreased oxygen going to the artery. This is the normal consequence. So there would be also decreased oxygen in the artery. And since both of them are decreased, the difference between them is gonna be maintained. So the AA gradient between them is gonna be staying in the normal range. Is this clear, guys? Okay. Okay. Amazing. So let's go to next thing. For the AA gradient, however, I want you guys to know that most of respiratory questions, you're not gonna need the AA calculation. Why am I explaining it? Because sometimes if you're lost in the case clinically, if you don't know what the patient has clinically, you can do the AA calculation and it's gonna break up the differential diagnosis for you. But most of respiratory questions, you can actually know what is the disease or what is the answer just by knowing what clinically the patient has. And we're gonna do questions at the end of this session and you're gonna understand what I'm saying. So, is the AA calculation important to do it in every single question? It's not important. It's not important at first. You can answer the question without calculating it. However, if you got stuck, if you don't know what does this patient have, what does he has clinically, you can do the AA calculation, and it's gonna break up like half or more than half of differential diagnoses for you. So we're gonna talk about how we can calculate or how we can measure the AA and what is the normal ranges for the AA gradient. I want you to know that in all questions, it's gonna give you two things. There's gonna be two given. What are the two given things? One, the partial pressure of oxygen in the artery, and two, the partial pressure of CO2 in artery. It's gonna give you both of those. It's not gonna give you the partial pressure of oxygen in alveoli because it's not measured. We can get the artery, the partial pressure of arterial pressure of oxygen and CO2 from what? From ABG. So we're doing an ABG test, and this is gonna show you the level of oxygen and the level of CO2. However, the level of oxygen in alveoli is not normally measured. We calculate it. How can we calculate it without going into details? But there is a relation between the arterial level of CO2 and the alveolar level of O2. There's a direct relation between them. You don't have to know how did it come. You don't have to know like what happened, what is happening. You just need to memorize this equation. And unfortunately, in this webinar, this is the only equation that you should be memorizing. How to calculate the partial pressure in the alveolus. And it's actually easy. 150 minus the partial pressure of CO2 over 0.8. But the only rule in order for this equation to apply is that the patient should be in room air. If the patient's not in room air, this equation wouldn't work. Okay? Okay. So after calculating the partial pressure of oxygen in the alveoli, you're gonna subtract from it the partial pressure of oxygen in the artery. And normally, the AA gradient, what is the normal level of it? It depends on the age, but only I need you to remember those two numbers. Those two numbers are gonna be concrete. They're gonna make you answer this question, and every single time you're gonna see it. If the patient is middle aged, the normal AA gradient, or the let's not talk about the normal. The high AA gradient is gonna be more than 15. If the patient is old age, it's gonna be more than 20. There is an equation that puts the age in it, but it is very, very like it will take from you time and it's gonna make it more complicated. It is gonna be easy. If the patient is having a condition that leads to high AA gradient, it's gonna be so high up to that you don't need to do an equation to know it. Just know approximate numbers. In middle age, more than 15. In old age, more than 20. Okay? Before going to the next section, do you understand this, guys? Or any one of you has any questions? Okay. No, no, no. They're not gonna ask about the age cutoff. Just remember this. Middle age, the AA gradient that's gonna be high, more than 15. The old age is gonna be more than 20. Okay, amazing. Okay. Now let's talk about the diffusion problems, or not. Let's not call it diffusion problem. A problem that led to no transfer of oxygen from the alveolus to the pulmonary vessels. Okay. This process has three components. The first one is alveolus. The second one is interstitial tissue. And the third one is pulmonary vessel. And there could be a pathology in each component that is gonna lead to the same final end result, which is decreased oxygen transfer from the alveolus to the pulmonary vessels. And all of them, what will all of them lead to, or what will be the effect of them on the AA gradient? Do you remember, guys? If there's an affection of any one of them. Yes, they're gonna lead to increase in the AA gradient because there's less oxygen going from the alveolus to the pulmonary vessels. So there is decrease in the P partial pressure of oxygen in the artery. So the difference and the partial pressure of oxygen in the alveolus is the same. So the difference is gonna be higher. Okay. So let's talk about the first one. The first one is when there is fluid filling the alveolus. The alveolus is filled with fluids. So when there is alveolus filled with fluids, although that there is some oxygen here, there is oxygen. However, because of the fluids, the oxygen and the fluid is having a high dense medium. It is slowing down the diffusion. So, because it's slowing down the diffusion, there will be less oxygen going to the arteries. Okay? Do you know what are the most common conditions that will lead to fluid in the alveolus? Yes, pulmonary edema. What else? Amazing. Pneumonia. Amazing, guys. Amazing. Pneumonia and pulmonary edema. Okay, yeah, heart failure is gonna lead to pulmonary edema. Now let's talk about the problem in the diffusion itself. What may lead to a problem in the diffusion itself? Okay, so yes, ARDS is gonna lead to pulmonary congestion. Okay, now to the second part. The second part is interstitial tissue. So when there is an interstitial tissue affection or alveolar wall destruction, there is affection of the diffusion. There is decreased diffusion capability. Okay. Okay. So what do you know, guys? What are the most common conditions that may lead to decreased diffusion, or affection of interstitial wall, or affection of, or interstitial tissue, or affection of or destruction of alveolar wall? Yes, fibrosis and emphysema. Amazing, guys. Amazing. So emphysema is destructed alveolar wall. and fibrosis. Let's name it, or sorry for that. Okay. Let's put it in a general term. Interstitial lung diseases. Any interstitial lung disease, including fibrosis, including sarcoidosis, including hypersensitivity pneumonitis, anything that leads to interstitial lung disease is gonna affect the interstitial tissue. Okay? And the last one, affection of the pulmonary vessels. When there is affection of pulmonary vessels, the pulmonary vessels are occluded. So even though that there is oxygen in the alveolus, it cannot be transferred to the pulmonary vessels because the pulmonary vessels are occluded. What is the most common condition for doing this? Yes, most of you guys answered it even before saying it. Pulmonary embolism. Okay. So there is a concept here. I want to talk about the mismatch concept, and I know like sometimes it is confusing, so I want to break it down in an easier way. Okay, you should know, guys, what is V indicating and what is Q indicating. V is indicating ventilation. Okay, what is ventilation? As we said before, oxygen going from the air to the alveolus, and air going out, both of them. So air going in. This is the ventilation. What is the perfusion or the Q? It is the blood supply to the alveoli. So we have ventilation V and perfusion Q. Okay. And we usually use a ratio called VQ ratio. Why? Because it's gonna give us some differential diagnoses. Okay. Normally there should be similarity between the amount of alveoli ventilated and amount of alveoli perfused. If there is a discrepancy between them, what do I mean by discrepancy? Like there is an alveolus that is ventilated but is not receiving blood supply. It means that this alveolus is less perfused. Okay, and this will mean that okay. So I'm going to talk about the VQ ratio, but I just want to break the concept easily right now, and then I'm going to talk about how it's going to affect the VQ ratio. And there are some conditions that may lead to like hypoventilated alveolus while the perfusion is okay. Also, this is a problem. So let's talk about the two conditions, and you guys are gonna answer. Here, when there is less, not less, when the alveolus is filled with fluid, there will be decreased ventilation. There will be decreased V. Okay. What will happen to the perfusion? The perfusion is gonna be the same. So what will happen to the VQ ratio here? Do you know, guys? When the alveolus is filled with fluid, the V is decreased. However, the perfusion or the blood supply is not affected. So there is decrease in the V and the Q is normal. So the VQ is going to be decreased. So there is decreased VQ. Okay. And when there is, okay, let me tell you about this. When do we say that the patient is having VQ mismatch? It's going to be either that the VQ is higher than the normal range or the VQ is lower. It's not either. Sorry, it's not just one of them. Either that the patient is having low VQ or high VQ, we call this term that it is deviated from the normal range, we call it VQ mismatch. So those who have decreased VQ, we're gonna name this VQ mismatch. VQ mismatch. Now let's talk about the pulmonary embolism. The pulmonary embolism, the ventilation is normal. The V is normal. But what will happen to the Q? Do you know, guys? Because the blood vessel is occluded, there is decreased blood supply in the pulmonary vessel. So there is decrease in the Q. So here, the V is the same and Q is decreased. What will happen to the VQ ratio? It's going to be increased. Okay? And what will... Yeah, it's going to be increased. We also call the increase in the VQ, we also call it VQ mismatch. So mismatch could be named after increased or decreased VQ. It's just like a VQ outside of the normal range, whether it's increased or decreased. I know this concept, guys, is very hard. So if any one of you has any question, tell me before proceeding to the next one. Yes, if the perfusion is zero, the VQ is gonna be infinity. Yes. Does any one of you? It is not Tanya. It's not high yield. What the question you're asking is not high yield. Okay. So any deviation of the VQ, whether it's decreased or increased, it's gonna lead the terminology that we use for it, VQ mismatch. That's why in some questions you're gonna see a patient with pneumonia and he's telling you that the patient's having VQ mismatch, and with this would be the answer. And another question, you're gonna see the patient is having pulmonary embolism and he's gonna tell you that this is VQ mismatch, and you're gonna be confused. Like, how is pneumonia VQ mismatch and pulmonary embolism is also VQ mismatch? It's because pneumonia leads to decreased VQ, while pulmonary embolism leads to increased VQ. Either way, they are deviated from the normal VQ range. And that we use for both of them, whether it's increased or decreased, we call it VQ mismatch. So in questions, when we do pick... Okay, we're gonna go through questions, Sumaya. No worries, okay? Okay. So is everything clear here before going to the next section? Okay. Amazing, guys. Let's go. Okay. Now, let's go to the easier part. Normal AA gradient, but still the patient is hypoxemic. We said that the patient is hypoxemic when the partial pressure of oxygen in the arteries is less than 60. So the patient is having partial pressure of oxygen less than 60. However, the AA gradient is normal. Why is the AA gradient is normal in those patients? Because the process of diffusion, this process, is not affected. However, the air reaching the alveoli from the first place, or the oxygen reaching the alveoli from the first place, is decreased. So those who have normal AA gradient, the alveoli is not filled with fluid, they're not having pulmonary embolism or pulmonary vessels occlusion, and the interstitial tissue, or there's no affection of the interstitium or the alveolar wall. That's why they're having normal AA gradient. However, there's less oxygen reaching the alveolus in the first place. And there are two main division for those who have normal AA gradient. It's gonna be, don't jump into conclusions, guys. Yeah, high altitude is one of them, but it's not the main one. There are two classification. It's gonna be either that the patient is hypoventilated. What do I mean by the patient is hypoventilated? I mean that the patient is having less air getting into the alveoli, meaning that the respiratory muscles or not the respiratory muscles, the air itself is not going to the alveoli, whatever the cause is. Okay, okay. So what are the most common causes of this? Can you tell me, guys? Now the first one is the neuromuscular disorder. Why neuromuscular disorder may lead to this? Okay, so since all of you guys said it, yes, it can also be due to inhibited respiratory center. When there is inhibited respiratory center, there is less respiratory effort, so less ventilation and less air getting in. So anything that leads to inhibition of respiratory center, and the most common thing is CNS depressants like opioids. Okay. Now let's talk about there is the first part is a problem in the respiratory center. The second thing is that there is respiratory muscle affection. It could be either one of you guys said myasthenia gravis. Yes, the neuromuscular disorder or neuromuscular junction disorder like myasthenia gravis is gonna cause respiratory muscle weakness, so there will be decreased ventilation. So something like myasthenia gravis. And there's another thing. If the patient is having, yeah, my kyphosis as well. If the patient is having any respiratory condition that is leading to respiratory failure, eventually the respiratory muscles are gonna be fatigued. And when the respiratory muscles are gonna be fatigued, they're gonna make less effort because they are fatigued. So they're when they're making less effort, they're making less. They will lead to decreased ventilation and eventually will lead to hypoventilation. So myasthenia gravis is one of the examples, guys. Any neuromuscular disorder, any neurological or muscular disorder that is gonna eventually lead to decreased respiratory muscle effort. And there is a third category no one of you guys said. You talked about the respiratory center inhibition, you talked about the neuromuscular disorder, and there's something. Yes. Yes, amazing, Abdullah. The last thing is something that led to upper respiratory tract obstruction, like OSA, like obesity, when there is a obstruction of the respiratory tract. So, upper respiratory tract obstruction. Upper respiratory tract, like OSA, like obesity, anything that leads. Yes, pregnancy and diaphragm. Like, there are a lot of causes, guys, but anything that leads to decreased respiratory muscle effort, anything that leads to decreased respiratory muscle effort is going to cause hypoventilation. Upper respiratory tract obstruction. Like OSA, like obesity. Those are the main things that are gonna cause hypoventilation. Okay. So this is the first part of those who have normal AA gradient and hypoxemia. However, the patient could have normal ventilation and the AA is normal, and still they're gonna have hypoxemia. When is that? When there is less inspired oxygen in air. When does this happen? When the percentage of oxygen in inspired air is less than 21%. And this happens in what? Most of you guys said it, in high altitude. Because in high altitude, the percentage of oxygen in the atmosphere is gonna be lower than the normal level. Okay? So could you tell me, guys, what is a parameter I could use to differentiate between those who have normal AA gradient, between those who have decreased inspired oxygen or hypoventilation? Yes. CO2. Do you know why? What will happen to CO2 in each one of them? Okay. In those who have hypoventilation, they're not only not getting air in, they're also not getting air out. So there is no washing of the CO2 in those who have hypoventilation. And since they're not washing out the CO2, the level of CO2 is going to be increased. However, those who have low inspired oxygen in the air, they're not having hypoventilation. They're not having a problem in getting the air in or out. The air is getting in or out. The problem in them is that the percentage of oxygen in the inspired air is decreased. So the PaO2 in those who are in a high altitude is gonna be normal. Okay. And I know, guys, there's a lot of numbers here, a lot of things to be memorized. But as I told you before, most of questions, you don't need to calculate any one of those to answer it. The question is gonna be clinical. We use those parameters, the PaSO2, the PA arterial, the PA alveolar, and calculate the AA gradient. When you're stuck between a lot of answer choices and you want to break down the differential diagnoses. But most of the time, you can answer it just by clinically knowing what the patient has. Okay, the CO2 again. uh, Mayo, can you focus with me? I'm gonna ask you, and you answer what I'm asking. And those who have hypoventilation, they're having problem with getting air in and getting air out. So, what is getting out of the lung? The CO2. So when they are having a problem getting air out, the CO2 is gonna not be washed out. The CO2 is gonna be trapped in the alveolus and in the artery. So what will happen to the CO2 level in those who have hypoventilation? I want Mayo to got it trapped. Yes, it's gonna be trapped. And those who are having a problem in inspired oxygen, they're not having a problem in ventilation. They're getting air in and air out, but the inspired oxygen is decreased. But they can get the air out. So what will happen to the CO2 level of them? It's gonna be staying the normal level. Okay? Okay. The last concept I want to break down before going into questions is the dead space. And this concept is quite a little bit easy. What do I mean by dead space? The respiratory tract is composed of two components. A component that is involved in the gas exchange and a component that is not involved in gas exchange. So, the respiratory tract starts from the trachea. So, the trachea is going to divide into bronchus and then it's going to be divided to bronchioles. However, along the respiratory tract in this area, the trachea, bronchus, and the main bronchioles, they do not have alveoli and they do not have pulmonary vessels going into them. So they are not involved in the gas exchange. And since they are not involved in the gas exchange, they are called dead space. Why? Because they contain air that is not involved in the gas exchange. And in this scenario, we're gonna call them anatomical dead space. Why? Because they are having oxygen that is not involved in the gas exchange. We call it lost air or lost oxygen. That's why we call it dead space. And it's called anatomical because it's something anatomical. You can never change it. You can never change that the bronchus is not having alveoli or having pulmonary vessels, so it's not involved in the gas exchange. However, at the end bronchioles, they are having alveoli and they are having pulmonary vessels. So they are involved in the gas exchange. That's why we don't call those areas dead space. So far, so clear? Okay. Now let's talk about the physiological dead space. We talked about the anatomical. However, in the respiratory bronchioles or in the alveoli, not all of alveoli are receiving the same perfusion. The alveoli at the base of the lung are receiving better perfusion than the alveoli at the apex of the lung because of the gravity. And the alveoli alveoli, they're containing alveoli and they can do gas exchange if they receive blood vessels. The alveoli in the apex of the lung are not involved in the gas exchange. And since they are not involved in the gas exchange because they're not receiving perfusion or they're not receiving pulmonary circulation, we're gonna call them also dead space. However, are they gonna be anatomical? No, we call them as a part of physiological dead space because it's not something fixed. If you, by a way or another, led to more perfusion to the apex or to the alveoli in the apex, if you led to more perfusion in the alveoli in the apex, they're gonna be involved in gas exchange. They're gonna so the dead space in them is gonna be variable. And the most common condition that leads to increased perfusion in the apical lung is exercise or sympathetic activation. Exercise leads to vasodilation of the whole pulmonary circulation. So there is more involvement in the gas exchange, and they are converted from physiological dead space into alveoli that are involved in gas exchange. That's why we call them physiological dead space. They're not anatomical. Anatomical dead space, they are fixed dead space. You cannot, since they are fixed dead space, you cannot change this fixed state. Like whatever you do, they're gonna still not be involved in the gas exchange. So the physiological dead space, what is it? It is containing two things. One, the dead space from the alveoli not involved in gas exchange. And two, they include exercise leads to vasodilation of the whole pulmonary circulation. Okay, Nicole? It's gonna lead to vasodilation of the whole pulmonary circulation. So, in normal individuals, the apical alveoli are not receiving pulmonary circulation. But in exercise, the exercise stimulates the sympathetic system, so there is vasodilation of the pulmonary arteries in the apex. So those alveoli who didn't receive in normal situations blood supply, they're gonna receive blood supply in exercise, and this is only situational during the sympathetic activation. Okay, Nicole? Okay. So physiological dead space, it's gonna include the dead space of alveoli that is not involved in the gas exchange, plus already the anatomical dead space. Okay. So physiological dead space is the total dead space in the body. The anatomical dead space and the alveoli not involved in gas exchange. So far, is everything clear, guys? Is everything clear? Does any one of you guys has any questions? Because we're gonna go through questions right now. We're gonna solve some QBank questions. Okay. So, what is a condition, a pathology that would lead to increase in the physiological dead space? Or let me rephrase it: a condition that will lead to more alveoli not involved in gas exchange, or a condition that leads to decreased perfusion. Do you know, guys? Yes, pulmonary embolism. Pulmonary embolism. Why? Because pulmonary embolism is gonna include a lot of arteries. So those alveoli which were receiving perfusion in the first place because of the pulmonary embolism and included pulmonary circulation, they're not gonna be involved in gas exchange. So pulmonary embolism is gonna further increase the physiological dead space. Physiological dead space means that the alveolus is normal, there is air in it, but it's not receiving the blood supply for gas exchange. Okay, and pulmonary embolism, it is very pathognomonic to have three things. He can ask you about pulmonary embolism in three ways in the topic I talked about. First, what will be the effect of AA gradient from the pulmonary embolism? Do you remember, guys? Yes. So pulmonary embolism can lead to increased AA gradient, right? Okay. Two, what could be another rephrasing of it? Yes, Sumaya. The pulmonary embolism also leads to VQ mismatch. Why? Because pulmonary embolism leads to less perfusion, so it's gonna decrease the Q. So the VQ ratio is gonna be increased, so it's gonna cause mismatch. What is the third phrasing that the pulmonary embolism could do? I just explained it. Yes, amazing, Dr. Hardik. Increase dead space. So pulmonary embolism can lead to three things. So don't be amazed or don't be confused when you see a question asking about pulmonary embolism and the answer is increased AA gradient. Another question, pulmonary embolism, and the answer is VQ mismatch. And a third question, and the answer is increase in the physiological dead space. Okay. Okay, I wanted to explain something. No, I think that's it. Does none of you guys has any questions before going into the QBank and the things I explained? Okay, so let's start with the QBank right now. Give me a second. A 60, so I like in the step one, especially in step one, I like to read the last sentence first and then see the question. Which of the following best describes gas exchange abnormality present in the affected lung region? Increased physiological dead space, ventilation perfusion mismatch, normal AA gradient with low arterial PaO2, impaired diffusion, alveolar hypoventilation. Now let's see the question. A 62-year-old man presents with 5 days of progressive shortness of breath, cough, and persistent fever. He has no history of lung disease and does not smoke. His temperature is high. Blood pressure is a little bit high. Pulse is borderline. Respiration are high. Oxygen saturation is 90. Chest examination reveals reduced chest wall movement on the right side during inspiration, and percussion over the right lower posterior lung field is dull compared to the left. Breath sounds are over this region are diminished. The remainder of the examination is unremarkable. Which of the following best describes the gas exchange abnormality in the affected lung? What do you think, guys? Okay, so this patient, what does this patient have? This patient has pneumonia, right? Okay, and what does pneumonia do? Pneumonia leads to fluid inside the alveolus. Okay, and since there is fluid inside the alveolus, there is impaired oxygen going from the PA alveolus to the PA artery. Okay, so let's see which choice matched this. Okay, ventilation perfusion mismatch. Yes, because there is decreased V. Decreased V would lead. So I would think this is the right answer. And let's see it and see the other answer choices. And most of you got it right, guys. Amazing. So let's break this down. Okay. So why does this patient has pneumonia? Give me a second. Okay. So first of all, this patient has shortness of breath, cough, and persistent fever, and of acute symptoms. Whenever you have fever plus cough in acute setting, you should think of two things: either bronchitis or um, bronchitis or pneumonia. How we're gonna differentiate? We're gonna differentiate by examination and chest X-ray. Bronchitis or pneumonia. If you do chest X-ray and you found opacity, it's gonna be pneumonia. If you did chest X-ray and you didn't find anything, it's gonna be bronchitis. This is the first thing. On examination, pneumonia is gonna produce crackles and decrease breath sounds, while bronchitis is gonna produce wheezes. So, fever and cough, always think of differential diagnosis, especially if it is in acute setting. Think of pneumonia. So this is the first thing. This patient has pneumonia. And as we said before, pneumonia, what does it do? We said that it fills the alveolus. So there is impairment of oxygen going from the alveoli to the artery. So there is one increase in the AA gradient. Okay. Okay. However, guys, did I need to calculate the AA gradient here? He didn't give me numbers, but even if he gave me numbers, I would still wouldn't use them. I don't have to calculate it to know. Okay? So there is increased AA gradient. This is one. And I know this just clinically that I know that the patient is pneumonia. And as we said before, here we have decreased V. So there is decreased V over normal Q. So the VQ is going to be decreased V over Q. So this will lead to VQ mismatch. Okay. Let's talk about the other answer choices. Increased physiological dead space. What is the pathological condition that will lead to this? Do you remember, guys? Yes, pulmonary embolism. Yes, pulmonary embolism. And this patient is not pulmonary embolism. Normal AA gradient. The patient is not having normal AA gradient. As we said, the patient is having pneumonia. Ruzi, the most common cause of increased physiological dead space is pulmonary embolism. The most common that you need to know for step one. There are other things, but they're not high yield. Okay? Impaired diffusion across the capillary membrane. The problem is not in the capillary membrane. The problem is in the alveoli itself. It is filled with fluid. And alveolar hypoventilation. Whenever you see this answer choice, he doesn't mean that there is part of the alveolus that has pneumonia. It means that there is global hypoventilation. Global hypoventilation. AA gradient is normal. Normal in what, David? I don't get you. Okay. So alveolar ventilation means that the patients have a condition that decreases ventilation in all of the lung. Those who have pneumonia, they're just having decreased V in the affected areas. Yeah, and the AA gradient would be normal. Yes, AA gradient would be normal in alveolar hypoventilation. Yes. Andrea, yes, as I said, why is AA increased? Look at this graph or look at this drawing. The alveoli is filled with fluid, right? And when the alveoli is filled with fluid, will the and oxygen is here, like oxygen is not disappearing. The oxygen is there. It is in the alveolus, but since there is fluid in the alveoli, the fluid is conducting the air or diffusion in a lower rate than the other things. So the oxygen is going to take more time to go from the alveoli to the artery. So the PaO2 would be decreased. Decrease PaO2. And since the partial pressure of oxygen in alveoli is still the same. The partial pressure of oxygen in the alveoli is still the same. But the partial pressure of oxygen in arteries is decreased. What will happen to the AA gradient, Andrea? Yes, it would be increased because the partial pressure of oxygen in alveolus is still the same. And the partial pressure of oxygen. Okay, we're gonna have a question about the shunt, Idle. We're gonna have a question about the shunt. Okay. Um, okay, so is everything clear in this question before going to the next one? Okay, let's go to the next one. Okay, let's read this. Which of the following set of physiological findings is likely present in this patient? Normal arterial O2. Oh, okay. This one is not included in the one we explained, so we're gonna do this one. A 68-year-old man is brought to the emergency department due to 3-day history of fever and cough. Okay, so let me read the answer choice. Which of the following mechanism is most likely of the cause of this patient's hypoxemia? 68-year-old man is brought to the emergency department due to a 3-day history of fever and cough productive of purulent sputum. He also reports right-sided chest discomfort, medical history, significant hypertension, type 1-2 diabetes. Physical examination shows a patient is in mild respiratory distress. Temperature is 39.1. Blood pressure is normal. Pulse is slightly high. Respiration are high. Pulse oximetry shows an oxygen saturation of 88% on room air. Physical examination of right lower lung field reveals increased tactile fremitus and crackles. A chest radiograph reveals focal opacity in the right lower lobe. Laboratory studies are shown. Leukocyte count is high. Neutrophils are high. Band cells are high. What does this patient have? Before answering the question, what does this patient have? Do you know, guys? Yes, this is the same one as the previous one. This patient has pneumonia. Pneumonia is a very high yield concept. Okay. What would be the answer here, guys? What do you think? I want all of you guys to interact. What is the answer? What is the answer? Okay. Yes, most of you got it right. Perfusion of poorly ventilated alveolus. The same concept as VQ mismatch. The perfusion is okay in those who have pneumonia, but the alveoli, since it's filled with fluid, it is poorly ventilated. So this is the right answer. Why it's not diffusion limitation? Because there's no affection of the basement membrane. As we said before, not alveolar hypoventilation, not decreased FiO2, and not increased physiological dead space. We said this is indicating pulmonary embolism. Okay, so let's see another one. Yes, I think we solved this. Not this. Yeah, this one. Let's see. Okay, so let's see which of the Okay. Which of the following physiological changes is most likely responsible for this patient's elevated arterial carbon oxide tension? Okay. A 24-year-old man is brought to the emergency department after being found unresponsive. On examination, he is somnolent with a pinpoint pupil. Vital signs are normal. Temperature is normal. Blood pressure is normal. Heart rate is a little bit decreased. Respiratory rate is extremely decreased. The oxygen saturation is decreased. Arterial blood gas are shown. pH is low. PaCO2 is uh, a little bit not hypoxia to an extent, but he has decreased oxygen saturation. This is CO2, sorry. This is CO2. CO2 is high and the oxygen is low. Which of the following? Yeah, okay, this patient is having opioid intoxication. Which of the following most physiological changes is the most likely responsible for this patient's elevated CO carbon oxide tension? What do you think, guys? Okay, as you said, guys, this patient is having opioid intoxication. However, did you have guys to calculate the AA gradient to know this? You didn't have to, right? You just know clinically. And most of the questions are gonna be like this, guys. Most of the questions you don't have to calculate the AA gradient. But if we're gonna have to calculate it, let's do it right now. We said that the partial pressure of oxygen in the alveolus is gonna be 150 minus the PaCO2 64 over 0.8. I want to have calculator. So it's gonna be 64 divide 0.8. It's gonna So it's gonna be 80. So 150 minus 80 is gonna be 70. So the partial pressure of oxygen in alveolus is gonna be 70, and in alveolus is gonna be 70, and in artery is gonna be 56. So the AA gradient would be 14. And is 14 normal AA gradient or high AA gradient? This patient is, I think he's middle age, right? Yes, it is normal, since it is less than 15. So here the patient has normal AA. And since he has normal AA, we are broken down to two things. The patient is having either hypoventilation or decreased inspired oxygen. Okay? So this patient is normal. But however, we didn't need in any one of the questions we answered, we didn't need to calculate the AA gradient. But if you're stuck, like now, you know it. But if you're stuck, you don't know what should I do. Try to calculate the AA gradient. It's gonna make for you differential diagnoses. So let's hear just from the AA gradient without seeing the case. Let's exclude other answer traces. Decrease normal AA gradient. I'm for sure knowing that the patient is not having decreased diffusion capacity. Decrease AA gradient. It's not yeah, I'm going to explain the shunt right now, okay? But it's not shunt, okay? Increased physiological dead space. We said this happens in the pulmonary embolism, and pulmonary embolism leads to increased AA gradient. Decreased alveolar ventilation. This is the answer. Increased carbon dioxide production. This is not the answer because this means another condition, okay? Another condition not related to the lung. This is not something related to the lung. This means that the tissues or the cells are consuming more oxygen and they are producing more carbon dioxide. It's not meaning that we cannot clear out the carbon dioxide. So this is not the right answer. So just by knowing the A gradient, I excluded. Yes, yes, I'm going to explain the shunt right now. Okay, and it's gonna be the last thing in this webinar. So just by A gradient, without reading the case, I can know that the patient is either gonna be B or E. E is gonna have increased A gradient. I'm gonna explain it. But here, let's see this answer trace. This is the right one. Okay, let's break it down. And now let's talk about the shunt. Okay. Do you know what is the meaning of shunt in general? Could you tell me, guys? Yes. Shunt means bypassing, and it's usually called, or it is a terminology we use on the blood vessels. So when there is shunt, usually it is shunt from what? Like there is bypass from artery to vein, or artery to artery, or whatever. Shunting from a blood vessel to another blood vessel. Okay. So this what does this mean? It means that the blood is going from an area to the other without being changed. So shunting means that the blood is going from the artery to vein without any change. Without any change. Okay. We call this shunting. Okay. And the pulmonary circulation. Let's talk about the pulmonary circulation. This is the heart, and this is the pulmonary circulation. Okay. This is the artery, and this is the vein, and this is the lung. Okay. Give me a second. Okay. When there is a condition that leads to, let's break it down. Like let's break down this section into the diffusion diagram. When there is a condition that leads to blood fluid filling in the alveolus, when there is a condition that leads to alveolar filling of fluid, it means that the artery or the blood vessels, when it goes from the artery to the vein, it's unchanged, right? There is no change in the oxygen, there is no change in the CO2, there is no any change. So the blood vessel going here, or the blood supply going here, and the gas exchange, since the alveoli is not giving it anything, or it's not receiving any CO2 from it, so it's gonna be shunted from the artery to the vein without being changed. In this case, we call it shunt, pulmonary shunt, a right to left pulmonary shunt. Means right heart, because the artery is going from the right heart, and the vein goes to the left heart. It's called right to left shunting. Because the blood, sorry, because the blood is going from the right heart to the left heart without being changed. There is no change in the CO2 level, no change in O2 level, because the alveoli is filled with fluid. So, what are the conditions that will lead to shunting? Do you know, guys? Conditions that lead to fluid in the alveoli. Fluid in the alveolus. Fluid in the alveolus. What leads to fluid in the alveolus? Pneumonia? Yes. But let me tell you something, guys. Pneumonia, it is localized in one area. So, yes, it is localized in one area. So we don't use the terminology of shunting to it, although it is technically accurate, but we don't use it to the pneumonia a lot. But the thing that leads to fluid in all of the alveolus, there is fluid in all of the alveoli. Pulmonary edema. Amazing, guys. Some of you say PE. I don't know if they mean pulmonary edema or pulmonary embolism, but it's pulmonary edema. So, what is the condition of shunting? Pulmonary edema. Okay, because the blood is going from the artery to the vein or from the right heart to the left heart without being changed in any parameter, the CO2, the O2, or anything else. Okay, there are some congenital heart diseases that also lead to right to left shunt. There are some congenital heart diseases that lead to right to left shunt, like VSD, not VSD. Okay, so let's not go into details of it, but there are some conditions that lead to right to left shunt, and conditions that lead to right to left shunt, like the blood going from the right heart to the left heart, the right going from the right heart to the left heart, without being changed, without changing the oxygenation or changing the CO2, we call this shunting. But this is not high yield in respiratory section. Okay, what is high yield is pulmonary edema. So is everything clear, guys? Uh, okay. So I was happy to be with you guys today, and I hope that you learned something from today, and I made you better at respiratory in a way or another, and the things I did make you better. I want to just tell you that the recording of today, you're gonna find it on our Telegram community and on the YouTube community. I'm gonna put the link on the messages. I'm gonna put it in the messages, and there's also the Match Guy YouTube channel. I'm gonna put it down. Give me a second. If you like the webinar, I would appreciate any review. Yes, it is recorded. You can find it on the YouTube channel. I just typed it down in the section here in the comment section. I would appreciate. Yes, yes. Like there are like every week it's gonna be different. I think next week I don't know which topic they're gonna announce it. Like you can ask the support team. They're gonna tell you. Um, so you're gonna like we would like to have you in the community where you can ask your questions, see the webinars, see the announcement for everything. We also have the YouTube channel, and you're gonna see the recording on it, and the recording of other webinars of our my colleagues and the amazing tutors. And if you're interested in one-on-one tutoring with me, you can have 30-minute consultation. We can talk about the plan of your journey in the step one, and even in step two if you're studying for step two. And we can discuss this together in a free 30-minute session. And I was so happy to see you guys, and I would appreciate your positive comments. See you. And you're gonna see me in the next webinars. I don't think the next one, but maybe the one after. Okay. See you.